In this chapter, we are going to take you on the adventure of liver sonography. I must admit that I really love to perform liver sonography. This is my favorite part of every abdominal ultrasound examination. I really love to scan this organ from all the different planes and views we are going to show you in this chapter. But before we get on to ultrasound examination, we're going to take a short review of liver's anatomy to get a better orientation during our procedure. The liver is seated in the right upper abdomen and is our second largest organ in our body. With a weight of about 1,500 grams, it is also the largest solid organ in our body. It's seated directly under the diaphragm, to which it is attached by the pars affixor, and it's fixed to the ventral abdominal wall by the falciform ligament over here. For better orientation in our ultrasound examination, it's good to imaginate the neighboring organs of the liver. We can see the gallbladder over here at the visceral surface of the liver. We can detect the stomach in the neighborhood and also the transverse colon, which is normally filled with gas, which can block the view of our ultrasound beam. A special feature about the liver is that we have got 4 different types of vessel systems in this organ. We got the portal vein and its branches, the hepatic artery and its branches, the bile ducts, and the hepatic veins. What is quite special about liver blood supply is that 70 to 80% of blood supply of the liver parenchyma comes from the portal vein, and only 20 to 30% come from the hepatic artery. The hepatic artery itself originates from the celiac trunk. And an important fact to know is that blood supply of malignant lesions comes only from liver arteries. There is no connection to the portal vein system. And this is a fact that can help us in distinguishing benign from malignant lesions through contrast-enhanced ultrasound. Another vessel system we want to talk about are the bile ducts. In liver anatomy and physiology, the bile ducts, the hepatic artery, and the portal vein and its branches always go together. From the start in the portal triad to the liver hilum. And they also run together in the hepatoduodenal ligament. This is a very important structure we have to evaluate in every ultrasound examination. In the hepatoduodenal ligament, we find the common bile duct, which is transporting bile from the liver to the gastrointestinal tract. We find the portal vein that goes into the liver hilum, carries blood from the gastrointestinal tract to the liver, and we got the liver artery that brings oxygenated blood into the liver hilum. And you will see there's a special plane in our ultrasound examination where we can get a good view of this ligament. But the liver veins, the hepatic veins, they go their own way. Before we proceed to the liver veins, we want to take a look at the classification of the liver lobes. We divide the liver in 2 lobes, a left one and a right one. There are different approaches to this division. A more morphological, anatomical one, and a more functional one, which is orientating on the appearance of the vessels. For surgery, for example, a functional approach is more useful. In ultrasound, we also use a functional approach based on the internal appearance of the vessels. And we divide the liver in lobes and segments. Are you ready for the liver segments? Now, I must admit this is going to be complicated, but I will try to make it as simple as possible for you. As a key message, the liver has got 8 segments. And our orientation guide are the hepatic veins. We got 3 of them. The left, middle, and right hepatic vein, and all of them are draining into the inferior vena cava. Let's start with the middle hepatic vein, because this is the border between the left and the right liver lobe. I'm going to show you on this picture. We got the middle hepatic vein over here. This is the left liver lobe with its segments, and this is the right liver lobe and its segments. Easy, isn't it? But now we're going to dig deeper together. We divide the left liver lobe into 2 parts. And our orientation here is the left hepatic vein. We got a medial and a lateral part. Here between the middle and the left hepatic vein, we got the medial part of the left liver lobe. And here, left of the left hepatic vein, we got the lateral part of the left liver lobe. So now we proceed to the right liver lobe. We got again the middle hepatic vein as a border between our 2 lobes. Now we stay on the right side of the middle hepatic vein. And again, we divide this into 2 parts in the longitudinal plane. And we have an anterior part and a posterior part of the right liver lobe. So this is our longitudinal section plane to divide the liver into parts. And as you can see here on this picture, every part has got 2 segments, and a special one over here, segment 1, which is quite near the IVC, but we're not done yet. Now we need to slice our slices into a transverse plane to get the segments. As you can see, every part of the liver has got 2 segments, a cranial one and a caudal one. And so we need a structure that slices our liver into cranial and caudal parts. And this is the portal vein over here. So now we can start and count the segments. In our left liver lobe over here, we remember the border in between is the middle hepatic vein. We got the segments 1, which is quite near the IVC, then 2, 3, and 4, which you can divide in 4A and B. And in the right liver lobe, we got the segments 5 and 6, which are caudal, and 7 and 8, which are cranial. And our border between cranial and caudal segments is the portal vein. Phew, I'm glad I made this. I know this was complicated. And believe me, I'm doing abdominal ultrasound for many years now. But even I have to look at the poster of the liver segment sometimes. So don't give up. This concludes this rather theoretical part of liver anatomy. And now, let's get on to ultrasound examination. So now, what do we want to assess when we perform an ultrasound scan of the liver? First, we want to evaluate the form and size of the liver. This can be important because in different pathologies, the liver can have a different form, can be larger or even smaller. And we also have to evaluate the capsular contour, which should be smooth and can be quite coarse or lobulated in special diseases, for example in cirrhosis. Also important is to evaluate the atriogenicity of the liver, and especially in comparison with the kidney. Normally, the liver should have the same reflexibility as the parenchyma of the kidney, but it can be, for example, brighter when the patient has got steatosis. The next thing we want to know is if the parenchyma of the liver is homogeneous, because we want to find masses or collections if they are there. We also have to assess, and we want to assess, the vessels of the liver. We got the hepatic veins and its branches, which can be widened, for example, in liver congestion. We want to see the portal vein, which should have a positive flow in it. And we want to see the hepatic artery. We also have to evaluate the biliary tree and the common bile duct, because, for example, when there is gallstones or any obstruction of the common bile ducts, the small bile ducts in the liver will be widened. So here we got some measurements. The hepatic veins should be less than 6 millimeters in periphery. But I must admit, I rarely perform this measurement. I rely on visible assessment. The portal vein should be less than 12 millimeters. And the intrahepatic biliary ducts shouldn't be visible at all. When you see them parallel to the portal vein branches, there's high suspicion of cholestasis. Also, the common bile duct should be measured. Normally, it's less than 6 millimeters when the gallbladder is still present, and less than 10 millimeters when the patient has undergone cholecystectomy. For having the best preconditions, our patient should fast for at least 6 hours, if possible, to have an empty stomach. Now I'm going to give you a short overview of the different approaches in liver sonography. We got 2 longitudinal views and start with the longitudinal epigastric view, where we place transducer in a longitudinal position in the midline of the patient. Here we can get a good look at the left liver lobe. The second view is also longitudinal, but this time below the costal margin, below the costal arch. This is our longitudinal subcostal view. Here we place the transducer below the costal arch and have to tilt upwards to get a good view of the liver. Next, we perform a transverse view, also in the epigastrium over here. Put the transducer in a transverse position. Can also assess the left liver lobe. The next view is an oblique view and below the costal margin again, but this time in an oblique position. Also, we have to tilt the transducer steeply upwards to get a good picture. And the next view will give us a good plane for assessing the hepatoduodenal ligament. This is the longitudinal portal vein view. Again, the transducer below the costal arch, but this time in an axis between shoulder and navel. This is the longitudinal portal vein view. And at last, we got the intercostal approach, where we place the transducer in between the ribs in an intercostal space, and also can tilt it upwards and downwards, and also change the intercostal space.